Today, our topic is on iron overload and iron chelation therapy and the treatment of red blood cell disorders. So we know that blood transfusions have been a real benefit to many of our individuals in both the thalassemia community, the sickle cell disease community, and other of the communities that have red blood cell disorders. We know that having access to transfusion therapies has allowed individuals to live longer lives and then more productive lives. But we do have to recognize that the threat of having blood transfusions does carry the risk of iron overload. And iron overload needs to be screened for and treated when it's found. So today we're going to have a discussion about iron overload, about what it is, and how we screen for it and also treat it. I'm going to welcome in just a few minutes the panelists for today. We do have a couple of housekeeping rules. We ask that you hold your questions until the question and answer period. Now, you can put it in chat so that you remember it, or put it, go ahead and put it in a Q&A section, but we won't answer or address your questions until the end of all of the panel presentations. We also ask that everyone mute your phone, and particularly towards the end, when we do have that question and answer period, we will open up the session to the participants, but we ask that you keep your phones muted when you're not speaking. As you can see here, so we will have the panel presentations, then a question and answer session, and then closing remarks. Now, this session is being recorded so that it is made available for references for individuals that aren't able to attend today. So we do ask that you keep that in consideration, that we are recording this session in order to post it online. If you have any questions as you hear the panelists, please use the QA or the chat feature to send your questions to us, and we will go through as many of them as we can during the question and answer session after our last panelist. Now, I would like to go ahead and provide a land acknowledgement. We're grateful for the opportunity to gather, though virtually, on this land, and we thank the generations of indigenous people who have taken care of this land long before other nation groups came. In particular, we acknowledge the traditional territories of the Ajuwabi and Anishinaabe and the Mississauga of the New Credit, whose territory is covered under the Upper Canada Treaties. We also recognize the contribution the Métis, Inuit, and First Nations and other indigenous people have made in shaping and strengthening the province and this country as a whole. We also need to continuously educate ourselves about the colonial history of this country and understand how the wrongdoings of the past still impact the present and the future. I encourage everyone at this session to actively seek information and to take action. Now, to start our presentation today, we are having Dr. Pendergrass, who will be providing a presentation for us. He will be speaking about iron overload, and its relations to blood transfusion, how iron overload is screened, and then also how we can treat iron overload. So I'm going to allow now Dr. Pendergrass, if you don't mind, to share your screen and start your presentation.
See it. All right, let me just share my screen.
Okay, Dr. Pendergrass.
Yep.
I don't know if my introduction went through or not because you couldn't hear me. So to everyone, I'd like to thank you so much for joining the webinar today. We are having this webinar on iron overload and iron chelation therapy. We're happy to have joining us today Dr. Jacob Pendergrass, who is the medical director of the blood transfusion services. We will go ahead and we will start.
Okay, and are my slides
Yeah.
showing properly?
Yes, they are.
Okay, well, thank you so much for the invitation. It's a pleasure to speak on this topic. Um, it's an interesting topic. It is physiologically a little complicated, and the medications that have been developed to treat it are somewhat complicated as well. But I'm going to sort of try to walk us through the overall story, and it's actually taken a little while to kind of unravel all this from a research perspective. But the overall story of how iron is normally managed in the body and how that can go wrong and what we can do about it. So this diagram here shows how iron is normally regulated through the body. And you can see that there's a very small amount that's absorbed per day, 1 to 2 milligrams, and a very small amount that is lost per day through insensitive losses or menstruation. Um, and there's a lot of iron in the body all the time, kind of circulating around. So there's a small amount coming in, a small amount going out, and a lot that stays in the body, moving between your liver, which is where it's stored predominantly, and your red blood cells and your muscle, where it's used. And the reticular endothelial system, which is your macrophages, are mostly involved in just sort of moving it around, between those two areas. So the main takeaway from all this is that iron stores are really regulated by what you absorb in your body. That's what you have control over. There's no real effective way of getting it out of your body. Like there's no sort of excretory pathway. And I think this probably just speaks to the fact that iron, from an evolutionary perspective, was scarce. It was always in short supply. And so there was never any kind of need to have an excretory pathway. It was just sort of assumed that you would absorb as much as you could from what you ate until you had enough, and then you would stop absorbing. Um, the other thing, though, is that, given the fact that iron is sort of scarce, it's something that bacteria want. And so when bacteria are invading our bodies, what they are often looking for is iron. That's what they're seeking. They have all sorts of pathways to steal it from us. And we have all sorts of pathways, therefore, to hide it from them. So when we have inflammation and we know that bacteria are entering our body, we shut it down. We hide the iron so the bacteria can't get it. And that's an important part of the physiology, that when you're inflamed, you will become functionally iron deficient and anemic. So on a cellular level, this is how iron is sort of cycled through. You have transferrin, which is a molecule that binds iron. Transferrin then binds to the transferrin receptor. The transferrin receptor is then internalized by the cell. The iron is liberated by the divalent metal transporter. And then it has a few different places it can go. It can be stored in ferritin, it can be used by the cell, or it can be excreted back out of the cell again through a molecule called ferroportin. And this whole process here can go awry and lead to iron overload through a variety of mechanisms. One is transfusional iron overload. You simply are adding so much iron to the system through blood transfusions that it leads to an excess occurring. Another is hereditary hemochromatosis, where a molecular defect leads to excessive iron absorption. The sort of the intake pathway is thrown off. There is a phenomenon known as African iron overload. It's partly due to sort of dietary differences. There's thought to be a genetic component to it as well. I don't entirely know what that is. And then there's a process of ineffective erythropoiesis, which basically means when your body's ability to make a red blood cell properly is thrown off and it doesn't work well, that can actually lead to spontaneous iron overload. So we'll get into the differences between transfusional iron overload and ineffective erythropoiesis through this talk. So transfusional iron overload happens obviously from receiving regular blood transfusions. And, for this talk, we're going to be talking predominantly about hemoglobinopathies as the disease state that leads to iron overload through transfusions. Inherited bone marrow failure syndromes like Diamond-Blackfan anemia, is also a population that can be affected by this. It's important to kind of understand that the way that we transfuse these different conditions really differs. We tend to transfuse alpha thalassemia fairly minimally. It's just enough to sort of maintain adequate oxygen delivery. That's typically when your hemoglobin is greater than 70 to 80, and we just give transfusions sort of as needed. Beta thalassemia, that we have a different goal. Our goal here is to suppress ineffective erythropoiesis. The way we measure that is with a soluble transferrin receptor level, or that for a level less than 10 kind of corresponds to a hemoglobin of greater than 90. And that's usually through regular transfusions. And then sickle cell disease, our goal is different again. Here we're trying to replace a abnormal hemoglobin S, with a normal hemoglobin that doesn't cause vaso-occlusion. And our goal is to typically to get the hemoglobin S less than 30% of our total hemoglobin mass, and that's often through exchange transfusion. So these are all different ways that we transfuse hemoglobinopathies. They have different intensities of transfusion, and therefore they will load iron differently. But the overall burden of transfusional iron overload is really defined by how much iron is actually in each unit of blood, and that's about 250 milligrams. So I talked before about how we normally absorb about 1 to 2 milligrams per day through our diet of iron. Each unit of red cells is 250 milligrams. So it is a lot of iron that comes in with every unit of blood. And essentially, once you have exceeded your total body iron, which is normally around 3 to 4 grams, and it got up to 12 to 24 grams of iron, then that iron starts to actually cause problems. It actually starts to cause toxicity. And how long it takes you to get to 12 to 24 grams of iron depends on how much you're being transfused, how frequently you're being transfused, whether you're being transfused in an exchange transfusion. All these things kind of affect that. But in general, once you have been transfused more than 20 units, you can assume that you're up to that sort of, toxic level of iron overload. And various things that we can do, therefore, to decrease the need for transfusion, i.e. hydroxyurea or Reblozyl or luspatercept, those will also decrease the amount of iron loading you have. So the less you need to be transfused, the less iron overload you will develop. However, in some conditions, even if you're not being transfused at all, you will spontaneously become iron overloaded. That happens with hereditary conditions like hereditary hemochromatosis. But for the purpose of this talk, I'm going to really be focusing on ineffective erythropoiesis as a driver of this, which is basically something that is specific to beta thalassemia, not alpha thalassemia, not sickle cell disease, beta thalassemia. And the reason it happens with beta thalassemia specifically is because beta thalassemia has a lot of ineffective erythropoiesis. And what that means is that you have a very massively expanded bone marrow. And the larger your bone marrow, the greater the demand for iron by that bone marrow. And that demand for iron will override the body's normal signals that say there's too much iron in the body already. So erythroferrone is a hormone secreted by red cell precursors that basically shuts down the liver's own attempts to limit iron absorption. So the liver is saying there's too much iron on board. The bone marrow is saying, I don't care, we want more. And so that leads to progressively greater and greater iron overload. So in effect, when you have ineffective erythropoiesis and you have a lot of early erythroid precursors in the bone marrow as a result, you get this insatiable need for iron by your bone marrow. And that insatiable need ultimately drives iron overload in the rest of the body. So why do we have ineffective erythropoiesis just with beta thalassemia? It has to do with the toxicity of the alpha globins, which are now in excess. They don't have a beta globin to pair with, and the alpha globins are not good for developing red cells. They accumulate and they basically poison the red cell before it can even reach maturity. And that is basically the definition of ineffective erythropoiesis. The red cell is not maturing properly. It's ineffective, and therefore you get this massive increase in your bone marrow. Again, we don't see this typically with alpha thalassemia. We don't see this with sickle cell disease. This is a beta thalassemia problem. And there have been studies looking at how the rate of iron overload correlates with the size of your bone marrow. And one of the ways that we look at how much bone marrow you have is the soluble or serum transferrin receptor level. You can see on this axis that this tends to go up the lower your hemoglobin is. So the lower your hemoglobin is, the greater your bone marrow expands, trying to make up the difference, and the greater your soluble transferrin receptor level gets. And you can see there's a slightly different curve here for thalassemia major and thalassemia intermedia. But it was basically from these kind of studies that we identified what the hemoglobin needed to be kept at in order to keep the bone marrow from growing too large. So we know that spontaneous iron overload happens when your bone marrow is more than 5 times normal. That generally corresponds to a soluble transferrin receptor level of 10 to 25, which is therefore, what we try to keep that level below. And in essence, what this means is that even if you are not transfusing somebody with beta thalassemia, it's like if you have beta thalassemia intermedia, you will still start accumulating iron overload from all that ineffective erythropoiesis, and it typically shows up around the 3rd or 4th decade of life. So beta thalassemia major will load iron faster because of all the blood that's being transfused. But beta thal intermedia or non-transfusion dependent thalassemia will also become iron overloaded because of that expanded bone marrow, typically showing up around the 3rd or 4th decade of life. So what is the problem with all this iron? Like, why do we worry about the effects of iron in our body? It basically comes down to these little dots in this diagram. These dots are iron atoms that are not bound to anything. They're not bound to transferrin. They're not bound to the divalent metal transporter. They're just sort of loose. And these loose irons are known as labile cellular iron when they're inside the cell, and labile plasma iron when they're in the plasma. And labile means that they are highly reactive. And the reaction that they can cause is what's known as the Fenton reaction, which essentially means that they combine with oxygen to create free radicals, which is this hydroxyl group here. And these free radicals wreak havoc. They damage cells, they damage enzymes, they damage proteins, and they lead to tissue injury. So if you have so much iron in your body that you can't store it up in these safe places like ferritin or transferrin, you will eventually start to have excess amounts of labile iron, and the labile iron is what's dangerous. It's what causes the sort of the rusting, if you will, of the other tissues. And that shows up in a variety of organ systems. The 3 that we focus on most carefully when we're following our patients in clinic are the liver, the heart, and your endocrine system. And these will all manifest in different ways. With the liver, at first you'll see an inflammation in your liver enzymes. Then eventually you'll see the liver start to become scarred over. Then it becomes cirrhotic. Eventually, without treatment, it can actually develop cancer. With the heart, you start off by having disorders of the blood vessels. Then the heart itself starts having arrhythmias, extra beats, palpitations, becomes inflamed, and eventually it too starts to scar over and starts to fail in terms of its ability to pump. And then in terms of the endocrine system, this can affect your pituitary gland. It can affect your thyroid, your parathyroid, your adrenal glands, your pancreas. And as a consequence of all of those things, osteoporosis can result as well. So these are all things that we're constantly checking for in patients who we know have iron overload. Many of these do not actually cause symptoms until very far advanced. And some of the symptoms that you can develop are not specific. So you can become fatigued for many reasons. You can have weakness or aching joints for many reasons. But we check for these things when you come into clinic. And we say, like, are you developing any of these symptoms? We look to see how the liver is doing, how the heart is doing, how the endocrine systems are doing. And we try to keep that iron overload under control. The way in which we know how much iron is in the body historically was by doing a liver biopsy. This was still common practice when I started seeing patients in the red cell disorders program. That has now been replaced by MRI scans, which are safer, which are more accurate, and have really changed entirely how we manage patients with iron overload. We just send them for an MRI, and it will tell us how much iron is in the body rather than having to take a piece of the liver and study it through chemical investigations. Regardless of how you have measured the liver iron concentration, whether that's by biopsy or whether that's by MRI scan, we have found through observational studies that the normal liver iron concentration, which is around 1 to 3 milligrams of iron per gram of liver tissue, is around 1 to 3. You can start climbing to levels like of around 7 or so, and still not have any danger. And we know that patients who have beta thalassemia trait, for example, or hemochromatosis trait will have liver irons up to 7 and still not have no problems. Once you start getting past 7, that's when the liver starts to be injured. Once you start getting past 15, historically, that's when we started seeing problems with the heart. And you can see that the rate at which the liver iron increases over time varies. With hereditary hemochromatosis, it's sort of a gradual increase. It doesn't actually start to cause problems until your 20s or 30s. Thalassemia major, where you're being chronically transfused month after month, you get that past that threshold much earlier. So yes, so the liver iron concentration is typically how we sort of measure how much iron is in the body in total, because that's where most of the iron is stored. So if you have iron overload, 90% of the iron in your body will be in your liver. That's why we check the liver so regularly. The ferritin is a very rough estimate of how much iron is in your liver, but it's a rough estimate. There's many things that can affect your ferritin and that can throw that off. But roughly speaking, we know that once your ferritin is greater than 1,000 in transfusion-dependent thalassemia or beta thalassemia, that's when we think we should probably start checking the liver to see how much iron is there. 3,000 has been proposed as the threshold for sickle cell disease because sickle cell is a more inflammatory condition, and inflammation drives the ferritin up. On the other hand, if you have spontaneous iron overload, once you get past 500, that's when we start worrying about it. So the point at which we would say, let's start doing liver MRIs is driven in part by the serum ferritin. But the serum ferritin, again, is a rough guide. And we know that if you track the ferritin over time, 25% of the time, the way the ferritin is moving is in the opposite direction of the way that the liver iron is moving. So your ferritin can be going up while your liver iron is actually going down, and vice versa. So it's a crude estimate. Can't do liver MRIs like once a month the way we can do serum ferritins. So the ferritins give us a rough guide, but it's really the liver iron that really drives our clinical decision making. And again, this is just an example of a patient that you can see, roughly speaking, the ferritin and the liver iron concentration tend to correspond, but not always. Sometimes the ferritin will start creeping up because there's inflammation going on, and the liver iron is rock solid. So again, you can't get too concerned about the ferritin. It's a clue, but it's not the full answer. Other thing it's important though is that the rate at which iron loads in the liver is different than the rate at which it loads and unloads in other organs in the body. And so what that means is that it is possible for your liver iron to mislead you in terms of how much iron is going on, how much iron loading is happening in other organs. And because of this, over time, the amount of iron that is in your heart, that is in your endocrine system, is not going to necessarily be predicted by how much iron is in your liver. And I remember, again, in the days before we had cardiac MRIs, I would see patients whose liver irons looked fine, but they were going into heart failure. And this was an example of how the heart can load iron independently of the liver and really ideally should be monitored independently as well. The endocrine system, we haven't really figured out a way of doing imaging to assess for how much iron is, for example, in your pituitary. So here we do sort of more laboratory tests. We do lab assays of how the pituitary is functioning. We ask patients how they're feeling, and that's how we assess how the endocrine system is doing. But we essentially are doing three different systems separately. We're monitoring the liver, iron through a liver MRI, we're monitoring the heart through a cardiac MRI, and we're monitoring the endocrine system through lab tests and imaging studies like bone densitometry. So again, here's an example of just looking at the rate at which your liver iron concentration can increase over time. And you can see that the rate at which your cardiac iron increases is slower. It does increase, but it takes longer. And also importantly, looking at this here, you can see the left ventricular ejection function, which is a measure of how well your heart is beating. That will start to fail as a late finding when you're developing cardiac iron overload. So we don't want to necessarily wait for your heart to fail before we act. And that's why another reason why we check the cardiac iron separately. This is a study showing the correlation between your T2 star measurement of your heart and how strongly your heart beats. And you can see that when you're greater than 20 milliseconds, you're pretty much fine. Your heart is nice and strong. You don't need to worry. Less than 20, it starts to fall off. When it gets less than 10, that's when we're really starting to worry. And importantly, if you're looking at correlations between your left ventricular ejection function um, and your liver iron, you see that it's a weak correlation. Your liver iron has a weak correlation with your heart strength, whereas your T2 star measurement is a much stronger prediction. This is an important finding here, and this is again a reason why we no longer just rely on the liver iron to tell us how the heart is doing. We need a cardiac iron assessment as well. However, that does appear to differ by diseases. For reasons that are not entirely well known, sickle cell disease patients do not seem to develop cardiac iron overload. They are relatively protected from this. Patients with Diamond-Blackfan anemia, on the other hand, seem particularly susceptible to cardiac iron overload. So there's other stuff that affects this. What this means is that some patients with iron overload, we do cardiac MRIs for, i.e., beta thalassemia, Diamond-Blackfan. Some patients we don't bother. We don't bother with sickle cell disease. It's just so rare. So what do we do? How do we get the iron out of the body once it has accumulated? The simplest way is simply to take blood out of the body. Now, you can't do that in somebody who is transfusion dependent. They don't have enough blood to remove. But there have been studies looking at patients who have beta thalassemia major who are cured of their condition through bone marrow transplant and then could undergo phlebotomies. And this is a protocol where they would remove a unit of blood every 2 weeks, and they would just keep doing that and keep doing that until your liver iron was down to reasonable levels. And this works. It takes a long time to do this. So in this study, it took really 3 years of phlebotomies every 2 weeks before the liver iron concentration was brought down to safe levels. So again, it is an option if your hemoglobin is high enough to allow you to do this. It's simple to do. It doesn't cost any money. There's no drug side effects, whatever. It's relatively slow. This is something we can make advantage of with exchange transfusions. What we have found, however, that with sickle cell disease, where we do those exchange transfusions, manual exchange transfusions don't really look like they're an effective way of getting iron out of the body. It's just we're removing less through the phlebotomy than we're putting in through the transfusion that we give afterwards. So you will load iron less quickly than you will with, top-up transfusions, but you'll still load iron. Apheresis transfusions, like exchange transfusions done by an apheresis machine, on the other hand, look like they can actually hold your iron levels steady, and in some cases actually lower a little bit. So one of the differences between manual exchange transfusions and apheresis exchange transfusions is the effect they have on iron loading. Manual exchange transfusions will load iron, whereas apheresis exchange transfusions generally will not. Okay, so if you cannot phlebotomize and an apheresis exchange transfusion is not an option for you, then you're looking at iron chelation therapy. And here we basically have three drugs to choose from that are currently licensed. One is desferal. This was the first iron chelator developed. It's generally speaking uh, difficult to use, and we tend to reserve it therefore for patients who are going into heart failure. And why? Because although it's a difficult drug to take, it is a very effective quencher of labile plasma iron. It can completely neutralize it while it's infusing. And this has been shown to be able to rescue people who are going into heart failure. It can shut down arrhythmias quite quickly. Over time, it can lead to recovery of cardiac pump function. This is sort of our rescue drug. That is how we use this now. And it has been found, that with the introduction of desferal in the 1960s, and especially when we started using it, in a way that it needs to be used, i.e., with slow, continuous infusion during the 1970s, sure enough, survival has improved overall, and in particular, death from cardiac failure has improved through the use of desferal, which was introduced in the 1960s. But again, it is not a fun drug to take. You have to either give it by continuous subcutaneous infusions or a 24-hour IV infusion, which requires having a special central line placed, which itself can have complications of blood clots. The desferal itself can cause toxicity if you give too much of it. It can cause loss of night vision or color vision or even blindness. It can cause hearing loss. So for years, although desferal was shown to be keeping people alive with transfusional iron overload, there was tremendous need for an oral iron chelator, which you could just take by mouth and not have to go through all these needles and IV lines. The first one that was developed for this purpose was Feraprox. This is a relatively simple molecule to make. It's can be taken from maltol. This is the larch tree, which was used as a source of the maltol, which was used to make the deferoprone. Easy drug to make. And initially hospitals were making it themselves, right in their own laboratories. It has a bit of a history to it. Part of the issue had to do with concern that it was causing liver toxicity. This led to all sorts of controversies, as described in this book, The Drug Trial, lawsuits. Basically, we never had a proper phase 3 clinical trial performed of deferoprone as a result of this. This was particularly true in North America, where we just didn't have it available. But it is still one of the most common iron chelators used in the world because it's cheap. It's easy to make and it's relatively cheap. So there's a lot of post-marketing data that comes from this, even though we never had that true phase 3 clinical trial. And that post-marketing data has shown a few things. First of all, it doesn't cause liver fibrosis, as we initially thought. It does have other side effects, though. It can cause neutropenia, which in some patients can be fatal. It can cause joint pain, GI upset. It has a narrow therapeutic window. So again, it's a bit of it's a difficult drug to work with. It's also not even as good as desferal at getting iron out of the liver. It does appear, however, to be particularly useful in getting iron out of the heart. And so this is actually what we use this for mostly now. It's for patients who have significant iron overload in their heart. Deferoprone is another tool that you can use to get it out along with your desferal. Now, we have deferocerox, which is in many cases considered to be our first line therapy. It's a relatively easy drug to take. Only have to take it once a day. You don't have to monitor for neutropenia every day. It does cause GI upset and rash. It can cause renal and hepatic toxicity, so you have to monitor for that. But that is now what we use as first line therapy. Desferal we use for as rescue therapy for patients who have severe iron overload, particularly in their liver, and deferriprone for severe cardiac iron overload, particularly in your heart. These things can all be used in combination as well. But this is sort of the landscape of medications that we have for iron chelation therapy. Okay, so I will stop at that point, and pass this on to our other speakers, but I'm also available to take questions at some point. I'm not sure, Donald, when in the morning we'll be doing that, but whenever you tell me the questions are open, I'm happy to take them.
Wonderful. Thank you so much, Dr. Pendergrass, for that wonderful presentation. We will hold questions until the end. I estimate that's going to be around 12:35, 12:40. So we hope that you can stick around to ask questions, because I know I have questions I wanted to ask, but I do want to wait until we've had the other speakers had an opportunity to speak. Now, our next speaker is Dr. Robert Johnson. Dr. Johnson is a seasoned medical affairs leader with a strong background in hematology and immunology, who's currently serving as the lead of the field team, medical team for rare diseases at Chiesi, USA. So, Dr. Johnson, you can share your slides and start your presentation.
Wonderful. Thank you so much for that introduction. Give me one moment. Can you see my slides? Are they being presented? Oh,
No, we can't see your slides.
You cannot.
We cannot, no.
Okay.
You should be able to share your slides, but let me know if you're having any issues.
Yeah. According to this, it says it should be sharing.
Let me remove the spotlight. It's not sharing, no.
All right, maybe I'm gonna have this.
Let's see if I can.
Sorry for the delay. Is that still nothing?
Still nothing.
Okay.
No, unfortunately.
All right, hold on.
There we go. Okay.
There we go. Perfect. Sorry about that. So we're good?
Yes.
Wonderful. Sorry about that. So, hello, my name is Robert Johnson. I am the MSL manager. So I manage our for Chiesi Global Rare Diseases. I manage our hematology team. And we currently are supporting Feraprox, which was mentioned earlier by Dr. Pendergrass, in being able to treat iron overload. Specifically, what I'm going to be talking about today is some of the information and kind of give you some information as it pertains to iron overload. Specifically, we'll be talking about it in the context of sickle cell disease. However, some of these examples and some of what I will be discussing actually goes beyond sickle cell disease and can be utilized in a number of the other disease states in which transfusions are regularly required and iron overload is known to occur. Okay, just as a quick disclaimer, for those later on when we have our Q&A session, I am not a doctor. So therefore I really cannot go into any specific treatment options or give any clinical advice. However, I can talk in global sense as to what is being done in the clinic, as well as how one should assess and potentially can look at their potential, the role of iron overload potentially in their treatment options and their disease state. So again, my questions are really about more global and clinical and scientific in nature than any one specific case. So just to give you a kind of overview of who Chiesi is. So Chiesi is actually a family business with a long legacy of developing medical solutions to meet unmet needs. It's only recently that we've, within the last, Chiesi itself has been around for over 90 years. However, Chiesi Global Rare Diseases, which is where this particular part of Chiesi is from, we specifically deal in rare diseases because we understand and we realize that there is a specific need for us understanding of rare diseases. So in that nature, Chiesi really is involved in patient as well as developing and improving patient relations as well as finding new therapies. And for that reason, as you can see, we have over 685 researchers as part of Chiesi as a whole. 35 Chiesi programs, of which GRD or Global Rare Diseases is one. And even within Global Rare Diseases, we specifically have a team, the Hematology Immunology team, that is focused solely on rare hematological diseases. So the focus of this particular talk is kind of taking three approaches. One is really identify why does one need transfusions? What are the reasons? Dr. Pendergrass has already given quite a bit of a good overview with regard to that. So part of what we'll be discussing is actually just reformulation and a duplication of some of the information that he has already addressed. How does iron overload happen to me? So again, this question came up. Again, I am part of the medical team. And as part of the medical team, one of the things that we do is we speak to physicians as well as about iron overload as it pertains to sickle cell disease and beta thalassemia. And in the context of those conversations, specifically in the context of sickle cell disease, was that we identified that iron overload was occurring not necessarily by the prescribed way, which is chronic transfusion, which is what occurs predominantly in the context of beta thalassemia major, which was addressed earlier on by Dr. Pendergrass. But what occurs in sickle cell disease, because of the nature of disease and and some of the comorbidities that go with it, is that sickle cell patients actually get transfused on an episodic basis. So really as needed. And because of this as needed approach, the implications and the ramifications of those transfusions over time can actually get lost in the context of all the other issues and and issues that the sickle cell patients are having. And because it's not an immediate problem and doesn't show itself immediately, it actually becomes an issue later on down the road as they age, as they get older. This becomes a more prominent issue. So we wanted to try to address it early so people are aware that this is going on and aware of what are the ramifications and what are the things that are leading to this, as opposed to waiting for it to manifest itself as it tends to do as in the context of organ damage, whether it be liver, the heart, the endocrine system. If we can catch iron overload early, it's much easier to treat and all of the horrible effects of it can be mitigated. So that's really the purpose and kind of the focus of this particular presentation. And the last is how do you detect iron overload? And once it's detected, how do you treat it? So that will be the final stage and the final piece of this particular presentation. Again, we're taking it from a look Here's how it happens. Here's how you identify, and this is what you do once it's identified. So again, this is a more sickle cell focused talk. Again, some of this can be transplanted and utilized in some of the other hemoglobinopathies. So specifically for sickle cell disease, it's well established that this is a genetic disease in which a single point mutation occurs in the beta hemoglobin, making it now fragile. The result of this mutation causes a normal red cell, which is nice and plump and round, to become sickle shape. Not only does it change shape, but the changing in shape actually changes some of the dynamics and characteristics of that red blood cell. Specifically, what can happen is, one, they're more fragile. So while a normal red blood cell has a lifespan of about 120 days, the sickle red blood cells that is significantly decreased to become 16 to 20 days. Well, that decrease causes anemia because now you are reducing the amount of actually circulating blood cells. In addition, the sickle cell is actually also more sticky, for lack of a better word. And this sticky the introduction of stickiness to this red blood cells allows it to clump. So they now form aggregates where they wouldn't have normally. And it's this aggregation that causes the manifestation of is the real problem. It actually ends up blocking and clogging your arterial, your venous system. And that clogging is actually what's causing the organ damage, which is causing the pain that you feel. So again, it's the clumping that causes the blocking. Now that the organs and the systems are no longer being oxygenated by the red blood cells is where you get your damage. So that's really the process that's occurring in the context of sickle cell disease. So again, we're talking about blocking of blood flow. And because blood flows into many organs or is required for many organs to function and to work properly, you get these multiple manifestations and multiple problems due to the sickle cell. And this can potentially manifest itself in quite a number of different areas, causing different problems. So in the brain, it causes stroke. In the lungs, it causes acute chest syndrome. If it occurs in the spleen, you can get fever, infections, splenomegaly, many things can occur. Similarly, if it occurs in the genitals, that's where you get priapism. So again, because the requirement of proper blood flow is needed for many organ systems, that restriction caused by the clumping of these sickle red blood cells, therefore blocking that oxygenation, blocking that normal blood flow, is what's causing all the problems. And the longer this keeps going on, the more damage will occur in the organ systems that is not getting the proper blood system, the proper oxygenation. So again, if not taken early and if not dealt with at a proper basis, over time, you will get that true organ system damage. First manifests itself as pain and some of these minor things, but it's really a telltale sign that something major is potentially going on. In addition to some of these acute is some chronic issues that will occur. This occurs in the bones. Again, you see it in the brain, you see it in the eye, the endocrine system. So once again, this has a persistent long-term effect of this occlusion of the blood flow due to the sickle cell, gets acute symptoms which happen early and happen because of the immediate impact. But because of that, you can get these chronic impacts and these chronic problems that will occur. That happens because of prolonged damage, because of that prolonged deoxygenation that's occurred, lack of blood flow or insufficient blood flow through the various organ systems. So why are we using transfusion? So as I said, part of the problem is the sickle red blood cells. They are causing the stickiness, they're causing the clumping, they're causing the occlusion. One of the ways transfusions helps in dealing with that is by introducing normal blood into the system, you can actually decrease what is known as the percentage HBS cells. And by decreasing that percentage, you actually lower the possibility and the possibility of the clogging to occur, of that clumping. So you dilute out the sickle cells with normal cells. Ideally, what one targets, if this is the approach that one is taking, is to get a percentage HBS below 30%. The other is to increase hemoglobin level. So under typical situations, the average person has a hemoglobin level of about 14 to 17. What's interesting about this is that with one transfusion to hemoglobin level, there has to be an understanding of what that means in the context of sickle cell disease. Now, in the context of sickle cell disease, by definition of what this disease is, most sickle cell patients have a significantly decreased hemoglobin level at what is called baseline state. So it's just what they normally are. Now, most sickle cell patients can function, I won't say ideally, but they can function well enough at their normal baseline state. If one does not understand what that is, and especially in the context of someone who is not familiar with sickle cell disease, if they are just not aware of this normal decrease in your baseline hemoglobin level as a function of the disease, they may actually be transfusing to what is known as your hemoglobin level. So you may be getting transfused for a reason that actually is not needed for you. So it's very important to know what your baseline hemoglobin level is, or at least have an idea of what the range is. So when you're if you're in, this particularly happens in the ED, if one does not know that you're a sickle cell patient, or one does not understand what that means so far as your normal physiology or the normal way your body functions, they may be transfusing for a completely wrong reason. The other thing is to prevent specific sudden long-term complications. So once again, it is established there are known things where transfusions are actually part of the treatment paradigm, or part of what is required or could be used for treating a patient. That's specifically priapism, stroke, stroke prevention, for acute chest syndrome, and for severe anemia, as defined by the physician and the patient. If you notice here, pain is not a reason for transfusion. And what ends up occurring again, and part of the reason why we built this patient-directed presentation, is because what we found was that depending on on the emergency room that a patient was going to, there was an understanding or a lack of understanding of when sickle cell patients should be transfused. And sometimes people get transfused to help with pain. This is not appropriate. What is thought to happen and what is recommended by most hematologists, especially those who have an expertise in sickle cell disease, is to have what is called a pain management plan, so that you know that this is what works for me to specifically take care of my pain, and to be able to transfer that information of your pain management plan to whatever physician you are seeing who is treating you for pain. And it's that way that you will not be getting these transfusions unnecessarily, and you will actually be addressing the problem at hand, which is pain. So I put this out there as just something for the community to know, is that if you do not have a pain management plan, it is a good idea to work with your hematologist, to work with your physician, to develop one that's specifically for you, to have that, and to be able to have a way of transmitting that information to whatever physician needs to have it. Again, what we found is that this is primarily of importance and really becomes a valuable tool in the context of the emergency room, where it is an emergency room. A lot of things are happening. Perhaps you can't effectively articulate what's going on. So if you think about these and you plan in advance of these type of emergencies, hopefully you and the caregiver that's with you, if there is one, or somebody, will be able to accurately, coherently transfer that information over. Similarly with your baseline hemoglobin. Again, if all of this is kind of in a package, in a singular place that can be easily transmitted and that information given, it would make life easier for everybody, and you will be able to get the proper care that you need in those settings. So what are the risks of transfusion? So as we've spoken, and what the focus is here, is iron overload, which occurs through multiple transfusions. But also there's something called volume overload and inflammatory reactions in the lungs. This occurs when you're given really too much blood, and the transfusions are superseding what your body can take. Again, these are rare events that occur, but they can occur, and I just want you to be aware of them. There's also something called transfusion reactions and alloimmunization. Again, people are blood typed and they're given the correct blood type, but especially for some sickle cell patients who have had multiple transfusions over time, that can shift and change over time where you become more reactive to more things, blood products, and so forth. So it is a potential, especially for those receiving transfusions on a regular basis from multiple different sources. So again, it doesn't happen often, but it is a potential complication that can, and a risk factor that can come in the context of a transfusion. So when we're talking about transfusions, what exactly are we talking about? Well, like I said earlier, there are really two types of transfusion. One is called episodic transfusion, and this really is a single series of transfusions. It's needed to treat an acute problem for a limited time. The other is chronic transfusion. This is long-term. They're usually scheduled so that there's a periodicity known to the patient and to the physician of when these transfusions are happening and why they're being done. It's predominantly seen in the context of beta thalassemia major, where it is known that these patients are going to need regular transfusions, and the timing is pretty regular for them. So again, there's an understanding of how much blood is being given, when it's being given, and the risk and the potential of iron overload as that time progresses. It also can be used in the context of sickle cell disease for several reasons. One of the predominant is for patients who have had a stroke, who are at stroke risk. Usually they will also receive chronic transfusion. Usually it's lifelong, and again, it's at a regular interval. When chronic transfusion is given, there's an understanding from the physician and from the patient of how that affects the iron. So if you're getting regular transfusions, you know how much blood you're getting and you know how much iron is being put in your system. So there's a way of knowing, and you'll know you're going to need to remove that iron because this is going on. In the context of episodic transfusion, this sometimes does not happen. And the other part of episodic transfusion and about iron overload and iron deposit as a whole is that, as Dr. Pendergrass stated, and I'm going to reiterate because this is very key to understanding everything and to really being able to monitor and know what's going on with you, is iron put into your system is not removed out of your system, and it will stay there until it is removed. So iron overload can be, if not removed, a lifelong issue that only gets worse as you get more transfusions. I think that is key, especially for those in getting episodic transfusions, because every time you're getting that transfusion, whether it be today, tomorrow, or 10 years from now, the iron is going to remain. So it is critically important to realize and to understand that if you believe you've gotten transfusions over time, or don't know how many transfusions you've got, it's critically important for you to at least get some sort of idea of what your iron burden is. Doesn't have to be today. This is not necessarily an immediate thing that you have to get taken care of today, but it is something that you really need to get handled and at least get an understanding of where you sit today, especially if you know that you've gotten transfusions. It's critically important. And from that moment onward, to have a vague idea or understanding that every time this is occurring, I'm depositing iron into my body. This iron isn't going anywhere. And just to somewhat keep regular every year or 2 years to get checked. Serum ferritin, we'll go over the different ways. Dr. Pendergrass has already gone over the majority of the approaches, but really it's important at least every few years, if you're getting episodic transfusions and you know you've gotten transfusions, to get your iron level checked. So when you're getting these blood transfusions, what are we actually talking about when it comes to iron overload? Again, we've kind of gone over this and gone over in our last section, but for this, about 10 to 20 transfusions. After about 10 to 20 transfusions, this is over the course of a lifetime. This is not just a one-shot deal. Again, the iron doesn't go anywhere. That you probably have needed and are starting to get iron, your potential for iron overload increases. It built up, and as it deposits in organ systems, specifically the liver, the heart, and the endocrine systems. Again, it's not removed, so it has to be removed through what is a process known as chelation. As just to go over how you look for iron overload. So it's already been discussed earlier. So real quickly, serum ferritin blood test is a quick and easy way. It basically a serum ferritin of over 1,000. One then is what is considered to potentially be iron overloaded, and one needs to really address the issue. It is the most common utilized way. It does have some flaws and some issues, but it is a quick and dirty way of identifying someone who has a potential for iron overload. More definitive approach is what is known as an LIC, or liver iron checking your liver iron concentration. It's done through an MRI screening. It is recommended to be done yearly. Again, if you know you haven't had transfusions, then you can probably go every 2 years or so. But it's recommended, especially for patients for patients with hemoglobinopathies, to at least get your liver iron checked every 2 years. And ideally, what you want is an LIC to be under 7. Anything above 7 would imply and indicate that you're getting too much iron deposited in the organ and have the potential for, over a long period of time, some organ damage. So again, you want your LIC to be below 7. Okay. Now, how do you get rid of the iron? We've got, again, Dr. Pendergrass already went over these, so I'm not going to really delve too deep, but there are 3 approaches to get rid of 3 agents to get rid of the iron. They're called chelators. It is, in fact, the only way that you can remove iron out of the system outside of completely removing blood and doing phlebotomies or out of the blood by doing phlebotomy and so forth. But when it comes to getting rid of iron in organ systems, such as your liver, cardiac iron, endocrine system, chelators are the only way to remove iron out of organs. There are 3, deferriprone, which is an oral, is a twice-a-day tablet. There actually is a liquid formulation for this. It does have gastrointestinal, main side effects of gastrointestinal, as well as an incidence, and there is a warning for agranulocytosis and neutropenia. Deferrizarox, which is another oral agent, it is taken once daily. It also has GI issues, as well as it's known to increase your creatine as well as hepatic enzymes. It is deferriprone actually does not have an indication and can be used for patients with mild to moderate renal insufficiency. Deferrizarox has a indication and to be careful for that use in that patient population. Deferoxamine has been around the longest. It is a subcutaneous infusion, and it is dosed over time. So it's an infusion 6 to 8 hours. Historically speaking, deferoxamine usually was given at night as a patient was sleeping because of that long infusion time. However, as was stated earlier, there are ways to be able to do administration on a more regular consistent basis. It is taken orally, subcutaneously, but it does have its own set of issues, such as ocular, auditory, growth retardation. You can be allergic, and because it's subcutaneous, you can have local reactions due to the infusion of the medication. So in general, iron overload happens over time, chelation takes time to happen. So for chelation to really work, it's really about adherence. If left untreated, you can get significant organ failure. It's a silent killer. You do not know you have iron overload till you get organ damage. So it is important to take care of it and to get these type of to check your iron on a regular basis. And lastly, again, chelation therapy is the only way to remove excess iron. Once iron goes in through transfusions, it does not get removed unless you use chelation. And again, takes time for it to occur. So be vigilant. It will happen. And you can best know it by the trend. So you have a baseline, and over time, what you want to see is that baseline go down, or at worst, you just don't want to see it go up. That's how you know chelation is working. So with that, I'd like to say thank you. These are some resources that are available to you. If you'd like to learn more or learn more about iron overload. So thank you.
Thank you so much for that presentation, Dr. Johnson. That was wonderful to hear about. And so now our last guest speaker, but definitely not least, is Josephine Sarna. With over 50 years of living with transfusion-dependent thalassemia, Josephine has used her life experience as a patient to raise awareness, educate, and advocate on behalf of patients with thalassemia and other inherited blood disorders. She is a longtime volunteer in the thalassemia community who led the successful effort to include thalassemia patients in Canada's hepatitis C compensation plan. She was an integral member of the Canadian Blood Society's Community Liaison Committee. Josephine continues her volunteer work as a board member of the Thalassemia Foundation of Canada, now the president of the Thalassemia Foundation of Canada, and the Network of Rare Blood Disorders, while working full-time for the federal government. So right now, I'm so happy to introduce Josephine to talk about your experience.
Thank you so much, Dr. Ivy. So, hi everyone. I don't know if you see my warning. Okay, there. Can you see my screen okay?
Yes, we can.
Fantastic. Okay. Thank you very much for the invitation to present. And I am coming. So I don't know how many presenters reveal their age right at the outset, but no secret here. I'm older than 50. I'm about to turn 55 actually. So what I do have here is some personal anecdotes and stories in the context of iron overload and iron chelation. But first, I'm going to dedicate this to friends still alive and also some that we have lost along the way, because I carry you in my heart still. And I am going to tell you a bit of a patient story, but I will focus on iron overload and chelation, and I'm going to try to sneak in a little bit of the merits of collaboration and advocacy that happens around our treatments. So I've been called a lot of things, let me tell you, in my lifetime. But I think right now what I'm liking is talking about lived experience, or the latest I've heard is lived expertise. So without any further ado, I'm going to talk to you about, I'm a patient with beta thalassemia. I'm transfusion dependent, so I will have that angle to it. And in a sense, from what you've heard from Dr. Pendergrass and Dr. Johnson, it's a little bit of the cautionary tale. So in the case of transfusion-dependent thalassemia, you will definitely hear what can happen in an accelerated situation of iron overload, and that's the cautionary tale, because you could learn from our experiences for sure. So my story begins in 1973. I was 2.5 years old, and my parents from Italy noticed that I had I didn't have a lot of energy. I was a picky eater. Then I just stopped eating, because apparently I used to like hot dogs, and then I even stopped eating hot dogs. And so then I had an infection that wouldn't go away. So they brought me to the emergency room, and the pediatrician who was on call that night actually trained in Italy, where there was a lot of thalassemia major or transfusion dependent thalassemia. And so he was able to diagnose me pretty readily, where the family doctor didn't pick up on the hints that were I guess the symptoms that were being revealed ahead of time or earlier. So he told my parents that they had a very sick little girl, and that if lucky, I would live till I was 20 years old. And the reason behind that is because back in the 70s, there wasn't iron chelation. There was treatment, which was the blood transfusions once a month. And we already heard that those came with all sorts of, I mean, it benefits the treatment of anemia, but it causes all of that silent iron overload in my case, or in thalassemia for sure, it would have been in the heart that would have eventually been fatal, because at that time there was no treatment for what they call secondary hemochromatosis, iron overload. And I might as well mention this right away. Again, both doctors mentioned that it's stealth. You don't feel the iron symptoms necessarily. You might confuse them with being anemic or fatigued for other reasons. And so another physician had once called it iron overload, and basically the cardiac I guess the cardiac failure that comes with it, almost like falling off a cliff, because you go along just fine, and then one day you become very symptomatic, and it's not a heart attack. It might reveal itself more as a congestive heart failure, but it's very hard to climb up the cliff after you've fallen or started to fall off of it. So that was the prognosis my parents were given at the time when I was just about 3. And so in the past, I've already talked about this, right? Death would have been, well, before blood transfusions were regular, life expectancy was less than 5 years old. Life expectancy went up to about 20 years old in the 60s and 70s, thanks to the transfusions, but again, nothing to treat the iron overload. And then into the 1980s, life expectancy definitely increased into adulthood. Because there were chelators that could treat. And so I'll talk to you a little bit about that. There were, of course, many other complications that we patients deal with regularly and we monitor. But I will say that I'm trying to tell you a very lovely story, because, we have patients now who are entering their retirement years. So that wasn't necessarily what their parents were told when they were diagnosed back in the 70s and the 60s. Okay, so this is a really busy slide, but I think what I'm trying to show you here is that the first issue is anemia. Whoops, I'm going to go back. The first issue is anemia, which is treated with blood transfusions, but then blood transfusions have all of these different side effects, including iron overload, which is what we're talking about. You could try to treat the iron overload. I'm going to talk about chelation because clearly phlebotomy isn't possible with somebody who can't make red blood cells. But chelation had all sorts of its own issues. Now, that's assuming someone actually took the Desrol, because that was the first chelator, because it's a difficult drug. You heard that too. It was subcutaneous. It was a known irritant to skin, and basically kids were told, tough it out because this is all you have. A little bit more kindly than how I just described it, but it really was just all about tricks on how to try to alleviate that pain from the difficult irritating medication. But later on, we learned that there were other problems, and you heard about that too, right? So patients weren't growing to a good height, like a normal stature, let's say. And then there were issues with vision loss and hearing loss, not like complete blindness, but difficulties due to the chelation. And again, this has to do, I'm saying chelation, but these first 3 were real associated with deferoxamine, and then these other 2 were kidney function associated with spherocyrox and a granulocytosis associated with deferiprone. So, and where did we see iron overload? It was in, and you heard this already, heart, liver, endocrine system. So, you know, we were normal, but not normal. And so then it continued to be a bit of, well, a lot of a slog, difficulties. So I've already talked to you about this. This is what I lived for the first 2, 3 decades of my life. And then and I'm going to show you what Desferal looks like. So subcutaneous Desferal involves these little vials of powdered medicine. And sorry, I didn't mean to have the brand in there, but it's a photo from another person. And it came with these supplies. So syringe, a subcutaneous needle, the sterile water, the pump. This is a battery operated syringe driver. There are also another pump which held a week's worth of supply, or holds a week's worth of supply, and can be infused intravenously or subcutaneously. But essentially every night this little thumbtack needle would go into arm or leg or tummy, and you would basically have to strap this to yourself to walk around or be able to sleep with subcutaneous Desferal. Now there's also intravenous Desferal. This is my friend Amy, who is also a board member of Thalassemia Foundation of Canada. And she has a PICC line and you can see in her pocket down on the right side of the slide there, her side pocket holds her CAD pump. And so with this really long tubing, she is able to do things like work full time, go out, meet up with folks and friends, and of course do chores around the house because her mother would not have it any other way. But again, you're carrying around a pump and you learn to fight it or hide it discreetly, but it's an involved process. Once a week, she will go to a home care center to get her PICC line changed. All right, so I like to talk about things in chronological order. So I just put up this timeline to help give some perspective of where we came from being diagnosed to getting the first treatments to having those first hopes of living past 20 years old, thanks to irritating but life-saving chelation. All right, so now I guess this is where I'm going to put some of my time, and it's talking about what patients have to go through if they are being monitored for iron overload, whether it be due to whether it be connected to sickle cell disease or thalassemia. You need to see specialists, and there's a lot of systems. There's, of course, you're going to see your hematologist, hopefully more than once a year, but there's complications that happen due to iron overload. So you're going to go see a cardiologist. You're going to see an endocrinologist, sometimes two, depending on if you have major complications, or if they're interested in your disease, because that's a whole other conversation for another day. But if you're on Desferal, you'd be getting your eyes checked and your ears checked. And of course, there are the complications of not just chelation, but of course the iron itself. So you're going to see maybe a liver specialist, and if you have issues with some of the side effects of those chelators, then maybe even you'd see somebody who's an expert in kidneys, such as a urologist, and that's just the specialists. Then of course they all have their own tests, and so they will send you for an MRI of the heart, an MRI of the liver, eye test, hearing test, bone density tests. What's the other one? Liver biopsy, maybe, hopefully not. And things looking at your liver functions. And those are the big tests where you have to book time and, be like an MRI, you have to dedicate the hour in the tube. And then others, of course, are extra blood work, which of course I think as chronic patients we're very used to. And so we are constantly being monitored for other related health issues. And of course, with some of these other health issues come treatments for them. And so there are patients who might be on cardiac medicines or are taking bone building medicines to counteract osteoporosis. They might be on insulin, that sort of thing. Luckily, in the case of hepatitis, there is a curative therapy, very expensive, but again, it is possible to actually eliminate hepatitis these days, which is wonderful. So I've talked about specialist tests and medicines, and what I haven't, and I've intimated that there is time commitments to all of this. There is also great expense to all of these. Some of these things are covered through third-party health insurance or say provincial health plans, but there are a lot that aren't. So I will talk about a lot that aren't covered later. But going along in time here, we have now not just transfusions and chelation, but we have options in chelation. There are 3 options, which is fantastic. And it has opened up the possibilities for patients. And so I'm going to talk about collaboration now, because this will go into helping each other to deal with burdens of healthcare, of chelation. And so I just want to thank collaborators like Sickle Cell Awareness Group of Ontario. We do help each other. We share resources. And so one that I would like to point out that's available online is the guidelines for management of transfusion-dependent thalassemia, because there is really good information in there about chelation therapy as well. This is not the only source. Dr. Johnson actually shared a really good source as well in his slide. But coming together to share resources and coming together to share our voice is really, really important. And because together we have this lived expertise and we are able to speak up for others. And on top of that, we are able to pool our resources to try to get better treatments and improve our accessibility. And I'm going to talk about, and that might be called advocacy. I just call it speaking up for ourselves. Now, advocacy in thalassemia has happened from a really long time ago. I have a daughter who's a history major, and she is starting to do archival search, like newspaper article search for stories about thalassemia. And back in 1979, the headline was 50 children denied life-saving medicine, and it was about deferoprone. Sorry, it wasn't about deferoprone. It was about deferoxamine. I have had the privilege of having tried all 3 medicines. Desferal, I was on Desferal for 20 years, 25 years, I think. And I was part of the clinical trial for deferoprone, and now I'm currently on the last one, deferoxamine. But back in the 70s, we were denied access to medicine. It's expensive. Back then, it was $15 a day. That in 1979, that translates to it was $62 a day. And so in a year, it translated to $5,500 in 1979. In 2025 dollars, that translates to 20, no, I've already forgotten, sorry. I'm going to say over $25,000. I think our expenses on Desferal is even more than that. And the other medicines are also very, very expensive. We have advocated for medicine, and it is now covered under some provincial plans and definitely through third-party insurance. We had to advocate. We joined what our hemophilia brothers and sisters had to do to ensure that our blood was safe and free of infection. We had to advocate for medical technology. Liver biopsy is used to assess your iron overload in your liver, but it comes with some major complications, and you could have a severe complication from a liver biopsy. So something non-invasive like an MRI, we had to fight for that, and it is now available. And I have this picture of an infusion pump. This is the one that my friend Amy uses. This thing costs $5,000. And so although the medication Destrel is available and at no cost to patients, I'm talking about Ontario now, the CAD pump and the tubing and the cassette are not covered. And so these are still out-of-pocket expenses for a vital life-saving medicine. And it rears its ugly head all the time. We talked about it in 1979. Our parents were fighting for us then. And today I'm still receiving phone calls from hospitals asking how to get a patient onto Destrel because they can't afford the supplies. And so anyway, like I said, strength in numbers. We come together with SCAGO and other organizations to speak about our stories and to talk about how the fight isn't over. We still need to access these life-saving medicines. There's no if, and, or buts about it. There's no choice. We have to be on these medicines. But wow, what a journey. Through advocacy, we have made change. We contributed to a new blood system. We contributed to getting hepatitis C compensation for those infected through the blood system back in the 80s. We are giving our voice to getting coverage for new drug therapies in thalassemia, and we continue to engage on blood safety. So I am finishing my talk there. I do have to obviously thank my family. Without them, I wouldn't be here. So thank you very much.
Thank you so much for that presentation, Josephine, and it's been wonderful partnering with you at SCAGO. I remember going on the the Hill with you to talk to legislators about how can we make it better for individuals with blood disorders, with all blood disorders, recognizing first that we're all treated by hematologists. And the fact of the matter is that there just isn't enough Dr. Pendergrass. As you pointed out, we do run into situations where there are other doctors that, they just, a question of treating us. But thank you so much for that. I now want to open it up for questions, and I'm going to start with the questions that we did have in the chat. And Dr. Pendergrass, I know you answered the questions in the question and answer, but I'm going to read them again aloud. And if you don't mind just answering them aloud for others that are on. And the first one is there a distinct benefit of doing phlebotomy versus staying on chelation after bone marrow transplant or gene therapy?
So the advantages of phlebotomy are that it doesn't cost anything, like you don't need a prescription for it. It doesn't have any kind of side effects, like stomach upset or renal or hepatic injury, that the medications can cause. So I tend to reach for phlebotomy whenever it's an option for me. There are situations where you want to get the iron out of your body faster than phlebotomy can do that. Sometimes it's because the amount of iron that's there is dangerous. Like you can't wait for years to get it out. It's going to, cause injury if you do. And other times, patients don't want the tedious, coming into hospital to get the phlebotomy over and over again. They would rather just take a pill and deal with it that way. So it's a conversation. But I always, when I see a patient who I think is eligible for phlebotomy, I always propose starting with that and then seeing how we do.
Okay, we are going to go to a live question. So we have Marlene Scott. I'm going to allow you to talk. So if you could unmute yourself and then ask your question.
All right. Good afternoon. Thank you so much to all the speakers and to Skego yet again. I'm currently being transfused via apheresis for stroke management. I began transfusion in June 2024, and I've since done 16 transfusions in 13 months. I've been moved from every 4 weeks to every 3 weeks. I've oftentimes reacted negatively during or after treatments. So sometimes, even while I'm still at the hospital, I'm feeling sick. This happened at my last transfusion, which was just Monday. Question, should I be having conversation with my care providers based on some of the things that were mentioned earlier? That is about iron overload, whether we need to be getting rid of it, or special MRIs to detect this? Or should I just assume that because they do blood work every time I go, like iron overload would show up in my blood work? Questions for the experts.
I'm gonna leave it for Dr. Pendergrass because this is a medical question.
Okay.
I have to
Happy to
bail
take.
out.
So I think apheresis exchange transfusions rarely cause iron overload. Sometimes they can, but it's rare. If anything, they can actually cause a little bit of iron deficiency because they're taking so much of the blood out. But most apheresis protocols do involve checking the ferritin with your monthly blood work. And once that ferritin is like climbed greater than 1,000, the physician would be sort of like, huh. And definitely if it gets to 3,000, they'd be like, you need a liver MRI just to see what's actually going on there. But yeah, it would be really rare for that to happen, and they probably are keeping an eye on it. I will say that the feeling really sick after the transfusions, I suspect that is a complication of the anticoagulant, which is added to the blood. It's called citrate, and in large quantities, when that gets into your body, that can cause a fall in your calcium level, and that can make people feel nauseous and lightheaded. It's not a pleasant feeling. Most apheresis protocols will have an infusion of calcium running into you while the procedure is being done to keep that from happening. But they're just kind of estimating. They can't actually measure your calcium like every 5 minutes during the exchange. So if you're having those symptoms while they're doing the procedure, tell your nurse. They can turn the calcium up a little bit. You can also try chewing some Tums or just drinking milk. That may also help a little bit too. If all else fails, you can actually take that unit of blood just before you transfuse it and spin it down to replace all the additive solution or the anticoagulants, and just suspend it in something that doesn't have any citrate in it. If you remove all the plasma, the blood won't clot as well. That's a lot of work for the blood banks to do that. And as somebody who works in the blood bank, we sort of try to avoid going to that step if we can. But if all else fails and you're having those really kind of like unpleasant, feelings of feeling nauseous or maybe tingling around your mouth after the exchanges, spinning the unit down before you get transfused is called plasma volume reduction. That can help prevent that.
Wonderful. Thank you so much.
May
Dr.
I
Pendergrass.
say one piece, which is, Marilyn, your doctors will keep an eye on things, but you also, I assume, will have access to your medical chart, like your e-chart. I encourage you to keep an eye on your ferritin as well and ask those questions of your physician. So don't assume. Make it your business to ask about yourself.
Totally agree
Yeah.
with that. Yeah, absolutely.
Yeah, definitely. And as you said, Josephine, we don't want individuals to fall off that cliff. That's why we want to have sessions like that, so that we're educating the community, making them aware, so that they can take the actions they need to, and be, hey, speak to your doctor, take the initiative and say, I need this done for me. I need that done, so that we are avoiding that cliff.
You're your partner in it. Yeah.
Sever Hussein, I think you wanted to ask a question. You're welcome to ask if you still had a question to ask.
Hi, everyone. Can you hear me?
Yes.
Sorry, I'm just at a taco, so I'm just going to leave right now. Lunch. First of all, thank you very much for the presentation. I really appreciate it, and it was very informative. And hi, Josie. It's Seaver. How are you?
Hi.
Thank you for your backstory. It was really nice to hear. Dr. Pendergrast, I have a question for you. I heard in your presentation you mentioned something about the third or fourth decade, something about the bone marrow, and if you could repeat that, I'm 33 now. I have beta thalassemia major, and it's just something I wanted to be aware of, and I want to hear it again if that's okay.
For sure. Yeah. So I was really referring to beta thalassemia intermedia, or non-transfusion dependent beta thalassemia. And the significance of the third and fourth decade for that diagnosis is that's about when you develop enough spontaneous iron overload that you start to get into trouble. I've seen this, patients who have beta thalassemia, they don't need to be transfused, they're feeling pretty good. They don't come to appointments after a while. They're like, I don't want to, come to hospital all the time. So they don't, but they do eventually come back to us. It's typically in their 30s and 40s. And by then the iron overload has caught up with them. And then they do need the treatment. Your situation with beta thalassemia major, you would have become iron overloaded, long before that. Like, before you're like 10 years old, you would have had iron overload for the transfusions and would have been receiving treatment for it as well. So wouldn't apply to you. It's really for the non-transfusion beta thal patients, who are in many ways, luckier. They don't need the transfusions, but eventually they need to get on chelation too. It's just it just takes a little longer.
Okay. Wonderful.
Awesome. Thank you, doctor.
We do have a question from Michael, which was put, Michaela, I meant to say, I apologize for that, which was put in the chat for Josephine. It says, her daughter is 2 years old with beta thalassemia and is transfusion dependent and just started chelation. In your experience with transfusions and chelation, have there been any side effects with your liver, kidney, or hearing, vision, or anything? Thank you.
Okay, so hi, Michaela. Thank you for the question. And isn't your child lucky? Isn't your daughter lucky that she's got 53 years on me? So things are looking good. And so learning, right? Now, okay, so when I started on Desferal, I already had some iron overload, so I didn't, but I was lucky enough to get into like this window of, I had been transfused maybe 5 years before I was able to, before Desferal was, I'm not gonna say invented, but like made available to patients in the 70s. And so I luckily did not have those side effects, but I do have peers who are just a little bit older, a little bit younger who did. So I'll tell you that, again, the physicians, the clinics, they have, like 50 years of learning, right? That your child is going to benefit from. And so they know to start the little ones at a much smaller dose, because one of the first learnings was they didn't think about Desferal toxicity, like and again, this is talking about the subcutaneous medicine, right? But they weren't sort of adjusting the chelation dose to the level of iron overload, and they do that now. So you won't have and it's because of the learning. They learn that you can't over chelate, and that could be detrimental to the child. I had a little bit of ringing in my ears when I was amazing with my chelation, but and so it brought down my ferritin really low. I don't know what my iron level, like iron concentration in my heart and liver was in those days. It was pretty good, I think. But my ferritin went down to something like 200 or 400 at one point. And they said, maybe you could hold back and not take your chelation for a month or two. And so then like I was off of it for 3 months, I think. And then I started up again because it reversed, like that side effect reversed. So luckily, but I do know some people, again, a little younger than me, so even less iron loaded than I was, who had some permanent hearing loss and vision loss, but that was on Desferal. I do know others who had had agranulocytosis and had that effect from the deferoprone. And again, they were able to recover, but it was a very long journey because they had succumbed to an infection at that time. So there are, like, these risks are real, but again, you're so fortunate, your daughter is so fortunate to have our lived experience to have that the physicians and caregivers have learned from, and they know to prevent.
Wonderful. Thank you so much, Josephine, for those comments. I will remind everyone that you can put your questions in the chat, or you can put them in the question and answer, or you can also raise your hands, and we can allow you to ask your question. I'll go to the question and answer again then. And this one, I imagine is for you, Dr. Pendergrass. I understand that Desferal is generally preferred for reducing liver iron, but the personal experience is that it didn't work for this individual, and that deferoprone was highly effective at reducing their liver iron. So she thinks patients need to have all options available to them and be closely monitored by their healthcare team. So if you could have any comments on that.
Yeah, no, I totally agree, Bessie, and thanks you for pointing that out. I'm talking about sort of like my overall kind of global approach for all patients is I tend to reach for deferoxarox first, and reserve Desferal for patients who have really severe liver iron, and the deferoprone for patients who have really severe cardiac iron as a general rule of thumb. But for sure, there are patients who really cannot handle the stomach upset that deferoxarox causes. Like it's really significant, or they have developed renal injury from it. And they don't want to take Desferal because it's an unpleasant drug to take, and so they end up on deferoprone, and it works perfectly well. So absolutely, it is definitely an option. And now it's actually licensed in Canada, so it's a lot easier to get it than it used to be. So for sure, I think, when you're sitting down and talking about starting on iron chelation, you need to lay out all the drugs that are available, even if you're going to recommend one of them to start with. But then every single appointment, when a patient comes in, you ask them, how are you doing on that particular iron chelator? Is it, should we make a switch, the dose, the drug, the route, and everyone will end up somewhere a little bit different. So for sure, it's a conversation between the patient and the doctor.
And Dr. Pendergrass, I guess I have a question. Have you any experience with using like two therapies? Like individuals have such high iron levels that they need to get them down, so you might use a combination of two of the iron chelators, or even the three. I can't imagine where three would be needed, but
Yeah.
Have you had any experience with that?
For sure, the most common combination is Desferal and deferoprone, and that's a very potent combination, because the Desferal is really good for getting all the iron that's in your plasma. Like, it just mops that up very quickly. It could also get the iron out of your liver pretty quickly. But Desferal is not good at getting into the heart. Deferoprone does. Deferoprone will kind of slip in there, bring the iron out, and then the Desferal will take it from the deferoprone, and then the deferoprone will go back into the heart and get more. There's this kind of shuttling kind of process. So that can really be super effective if you've got somebody who has really bad iron everywhere, like bad in their liver, bad in their heart. Those two things together can be really potent. I have tried Desferal and deferoxarox together on occasion, and I found that is just too potent a combination. Like, it drains the liver so quickly that you run out of room to move to get it out of anywhere else. Like, you sort of like everything, your liver iron goes down to nothing, and meanwhile your cardiac iron is still high. So I don't use that one very often. I have heard of people using deferoxarox and deferoprone together. I've never seen that. I've never found a patient who I feel like would be good for that combination, but yeah, I know that's been tried as well. So yeah, there's always to mix and match.
Wonderful. And Josephine, I think you were not in. Have you had experience where you were on two iron chelators at the same time?
I personally know, but I do know several patients on those two different combos. One took Desferal and Deferaprone, and another is on Desferal and the Defera. Sorry, Jane, you
Yeah.
Xerox. And again, for like severe iron overload, very unique situations. Again, I think what's what's wonderful now is that because there are options, it becomes more personalized. You know, your physician is going to look at your situation. They're going to look at where the iron is loading, and they're going to come up with the best combo or the best choice for that individual. And again, the lovely part is that if maybe the first try something didn't work, there are other options, you know, to try. So we're in much better times now.
Wonderful, wonderful. And I'll admit to the audience, so I have sickle cell disease, hemoglobin SS. I don't know if I mentioned that earlier on in introducing myself. I have had, you know, more of the sporadic transfusions that Dr. Johnson mentioned earlier. I received my first blood transfusion when I was in college, and I had an episode of acute chest syndrome. I know when I was in medical school, I had another questionable acute chest syndrome and had another blood transfusion. And then I've also had blood transfusions operatively before surgery. So I wanted to ask Dr. Johnson, Dr. Pendergrass, you know, so I'm hearing this about, hey, accumulative, you know, how many blood transfusions would it take? And given my history, you know, what screenings should I look for? I mean, should I go on to do an MRI, considering I only had about maybe 6 transfusions at most, or should I, is the ferritin enough?
Yeah, I think the ferritin is a good clue to keep an eye on. I think the way to think about transfusions and iron overload, the way I think about this sometimes is like you're pouring water into a bucket with a slow leak. And so, you know, if you are pouring in a unit of blood like, you know, every few months, odds are a lot of it will have leaked out, you know, by the time you do your next one. So it's not just the number of units, it's like how close together they were. So if it's like one or two here and there over the years, probably, you know, your body has leaked it all out anyway, and you're not going to be, it's more sort of like every month, boom, boom, boom. You pour another one in or another two in. That's when you get into trouble. And yeah, I think it's a good idea to check your ferritin every now and then. I think for anybody, you know, like it's a useful test to have to kind of just give you a quick clue of where you are, both to look for iron overload, but also look for iron deficiency. That can also happen, you know, and that's an important clue too. If you're becoming iron deficient and you're not sure why, you should find out why. So yeah, so I think most doctors who care for patients with hemoglobinopathies check the ferritin every now and then. I think, you know, Josie's point, don't just assume that, you know, like check yourself is good advice. But yeah, I would say that with sickle cell disease, um, if your ferritin is less than 1,000, you almost definitely don't need to worry about transfusional iron overload.
Yeah, no, I would agree completely. I think the issue is how many people are really know how many transfusions they've had in a meaningful way. I think that's the important part, is that if you're pretty sure that it's only been a couple here and there, I think you're probably, you know, check anyway. I mean, nothing can go wrong with that. But really you want to, if you're not sure, you really want to just double check, get a serum ferritin. Again, getting an LIC, it's an MRI, it's easy to do. So I would still get one done, but it's not immediate. It wouldn't be an immediate issue. But, you know, it's not a bad idea just to get that done periodically, just to be on the safe side.
Wonderful, wonderful. I do have a question for Josephine. So I know you mentioned that you were taking and I'm forgetting which one, I think is Desferal, where you had the injection and it was very painful. And it sounds like you started when you might have been younger. Do you have any advice for like younger children? So I know Michaela I hope I'm saying her ring. Michaela mentioned that her daughter is 2 years old and may have to be on this therapy. Is there any advice for individuals to take this therapy?
Yeah, sure. Like, okay, so Destrol, what is common is pump lumps, is what we call them, because it just sort of sits there under the skin and it feels hot and sore. But it's totally worth it. Okay, I'm going to get a little philosophical here. I am a parent, and it helps me reflect on what my parents did for me. And so consistency is a big piece. And so I don't know if this is where you're expecting it to go, Dr. Ivy, but I encourage everyone to to work with your physician and healthcare team really to get the best treatment for yourself, and to work as a team in monitoring and knowing that you're fighting this fighting a battle. Anyway, you're taking care of you as a team, and it's really helpful. As far as Destrol goes, there were all sorts of interesting tips and tricks, because it was things like, how do I hide it, and how do I administer it and make it easier? Don't try to rotate as much as possible, different sites. So arms, tummy, legs. I was a leg girl for like, I don't know, like 10 years, I think. And then I saw another patient actually take his needle out of his arm. And I thought, oh, maybe I should try that. And that gave me the courage to do it. But really, parents of kids on chelation, they are dependent on you. And even if the healthcare team wants them to learn, they will learn eventually, but be that steadfast, solid support to them, because they are going to learn from you and they will gain acceptance from you. That's what happened with me. And I didn't realize it at the time. And the other thing is, stay on it all the time. I don't know what the latest is on chelation, how many days, but when I was a kid and learning how to take Destrol, I was told by the nurse, only Christmas and your birthday are the days that you could skip. Every other day you have to have your chelation in you. And my mom really she really followed that. And so even if I whined, or if I tried to get a little bit, or if I got sad or really didn't want it, she really said, nope, doctor and nurse said, you have to take it. And so you're going to take it. And so it was that steadfastness that gave me, I think, like, she was my light, right? So it's so important to just stick with it. I'll stop.
Yeah, no, just to reiterate, and that's an excellent point, is chelation works best when it's in your system 24/7. So use that as your rubric. Whatever that means to you, however that happens, 24/7 is the best way to chelate, to get rid of the iron and to really mitigate all the issues. So you talk to your physician, you talk to whomever you need to, you figure out what combination, what works for you to get to 24/7.
Wonderful. We do have a question from Bessie. So if you could unmute yourself and ask your question.
Can you hear me? I think I've unmuted. Okay,
Yes.
perfect. Okay, thank you to all the speakers for this really wonderful and important topic. My question is for you, Dr. Pendergrass. I'd like to hear what your thoughts are on generics, iron chelators. Have you seen more patients react to generics differently than the brand name drugs? And I ask this for all, but also my own experience, which I did develop an allergy to desferoxamine after 30 something years of taking it. And I believe it was after I switched to a generic, but was never necessarily confirmed, but I'm just wondering if I was an anomaly, or have you seen in your practice for any of the drugs where generics are offered, if patients are having reactions or different levels of efficacy or any other issues?
Yeah, it's a good question. I think the generics play a really important role in keeping drugs affordable for people who don't have insurance plans that cover them. Generally speaking, the rule that we follow in medicine is we consider them to be interchangeable. So we just say that, we switch, as soon as it becomes available. Are there differences, in the way that they're manufactured? Probably. I mean, they are made by different companies. They're not made by the original company that had the patented version of it. And so there may be some subtle differences, in maybe some of the stabilizers that are added to the drug, maybe to the type of storage device that they're put into. There are some possible differences. So I would not say, it's impossible for this to happen. It is possible. But generally speaking, we assume that they're the same drug, unless we have pretty strong evidence otherwise. But yeah,
Okay.
I think most we treat them as the same.
Okay, and I know in Canada we have different standards around generics than maybe in some other global jurisdictions where there's more general concern around the production of generics. So I think that's something our patients can take comfort in, but I just was wondering if, we've seen that experience at all. Maybe it's something some other substance that's made in the generic that might be an allergen to somebody versus the brand name. I mean, I know people can react to the brand name drugs as well. So I just would want to know that patients, if that was their experience, would be able to move back to like the branded name drug and have coverage. In my case, I was lucky. I was on um, uh, combination therapy with deferriprone, and I just maintained myself on deferriprone. But I'd want to know that patients would have an option to go back to a
Yeah,
brand drug if needed.
it's always a conversation you could have. I mean, there's a tug of war, right, between the companies that originally manufactured the drug and had the patent on it. They want to hold on to that patent for as long as they can. And so they will, be advocating for, accept no substitutes, make sure you use this brand only, versus the insurance companies that want to move to the generics as quickly as they possibly can because it saves them a lot of money. And so, the patients are often caught in the middle between the manufacturer who maybe sort of says like, there's something special about our version, don't try those generics. And the insurance companies are saying like, there's no difference, just take the cheaper one. So I think it's for sure. If you have a pretty strong case to be made that that generic is just not working for me, then that's a conversation you can have, and you have to basically make your case to the insurer. You have to sort of say like, I medically think that this really is a real difference, and you as the insurance company really should be paying for the more expensive one. But they'll push back. They'll really want
Of course.
real.
Of course. Okay, thank you. I appreciate your thoughts on the matter.
Mhm.
Wonderful, wonderful. Thank you so much, everyone, to coming to this session today to learn more about iron overload. I want to, reiterate the point that Josephine made earlier. We don't want any patients falling off a cliff, and we're in this together. We have to look out for each other. We have to make sure that we're advocating for each other. There are patients in different circumstances. And so we got to make sure that we're working as a community to really improve the care for all individuals with blood disorders. So I would like to thank you so much, everyone, for attending the session today. I know there was a question in the Q&A that we weren't able to get to live, but it was answered by Dr. Pendergrass. I will have to ask if the slides will be available. I'll ask the presenters if they're willing to share their slides, and then we can make that available to the community. But the post will definitely be available. The video will definitely be made available to everyone. Thank you again, everyone, for attending this session. And I look forward. Before I go, I do want to just show one more slide, if I may, just very quickly. I wanted to just let everyone know that we are having the Sickle Cell Summit in August. And so please sign up for that, come out, learn more about new therapies in sickle cell disease, what's going on with policymakers. There is the new gene therapy, and it's not just for sickle cell disease, it's for thalassemia as well. And we will have the first recipient of the CRISPR gene therapy from the US come and talk to the community as well. So please consider marking your calendar for August 15th and 16th for the SCAGO Sickle Cell Summit. With that, thank you, everyone, and have a nice weekend.
Thank you.